So as Gail said, I'm talking about using with caution the hypomethylating agents. So just again, to just quick definition, low-risk MDS that we're using here can be any of the definitions of low risk, whether you use FAB, WHO, or IPSS. But as Gail mentioned, even lower risk MDS has a median survival of only somewhere between 3.5 to 5.7 years, particularly in those who are over age 50. And 25% of the patients with lower risk AML will still progress to, MDS will still progress to AML with a median time of somewhere between 3 and 9 years, depending on if it's INT1 or low risk. Survival is significantly longer in those under age 50, and comorbidities associated with age do impact on survival. The only curative therapy is transplant, but as you previously heard, survival after transplant is somewhere around 50% if you have a sibling donor, 45% or so if you have an unrelated donor, but toxicity is significant and transplant-related morbidity and mortality is real, and so it's not something we jump to in the low-risk patient population, even though the low-risk patients do have a slightly better survival than those who wait until they have advanced disease. That being said, Corey Cutler did look to see when we should be transplanting our patients with low-risk disease. And what you can see here is those who wait until they have higher risk disease do better than those who get transplanted when they're low risk. But this is a retrospective analysis, so you need that crystal ball to know when you should jump on the transplant, which is not always an easy thing to do. So hypomethylating agents in low-risk MDS. There have been several attempts to try and see whether or not there is an advantage to giving our patients hypomethylating agents. This is a retrospective analysis by the South Koreans that have looked at a group who got hypomethylating agents and then did a case control study looking at other patients in their population who they tried to match. And as you can see here, survival was better in the best supportive care group than those who got hypomethylating agents for low-risk disease. Even though they were not perfectly matched, even when adjusting for performance status and cytogenetics, hypomethylating agent use came out as a negative factor for survival. The Nordic group that Gail just mentioned, what they brought up in their study when they showed it was limited utility, which I think was of some benefit, is that a majority of the patients, those who are blue in those circles, don't respond, and that's probably the problem. It's a minority of patients, so only 5 of the 30 patients, and then they allowed some patients to get an extension. So only 1 of the 16 patients who then had erythropoietin added actually responded to the azacitidine. And that is probably one of the reasons that it doesn't help, is that we cannot necessarily predict who is and who is not going to respond, and we see significant toxicity from the hypomethylating agents. Those who responded did better, but if you look at their prognostic factors from the beginning, there is no difference in outcome and overall survival with the hypomethylating agents than you would have predicted in a group that would have not received them. The response duration is short. The time to leukemic transformation and the incidence of leukemic transformation is no different than it would be if they did not get hypomethylating agents. So can we predict? So there was one study that gave azacitidine to those that they considered unfavorable low risk. They define that primarily, at least retrospectively, as those who also had a low platelet count. This is by the Spanish group. And in the group that had unfavorable low risk MDS, they were able to show a benefit to azacitidine. So there's our maybe. Perhaps there is a patient population in whom there is a survival benefit to giving azacitidine to a group of patients with low risk MDS. Now, how do we define low risk? There are lots of different ways to define it, but none of them have really been shown to impact on what that means for administration of azacitidine. That study showed that low risk by virtue of low platelets defined a group of patients who could benefit from azacitidine. Age has been shown to be low risk, transfusion dependence, hemoglobin, bone marrow blast, karyotype, and you'll hear a little bit about mutations, but again, none of them have been shown to predict for azacitidine use. You'll hear that in the next talk. TP53 has been shown to increase your risk of leukemic evolution in a 5q- group. EZH2 has been shown in multivariable analysis to decrease overall survival. The others have been shown only in univariable analysis. SF3B1 is shown to improve survival in the RARS population. And TET2, I only brought that up because in the high-risk patient population, it has been shown to predict for response to hypomethylating agents, but that has not been looked at in the low-risk population. So what are our goals of treatment in low-risk MDS? We want to improve survival. We also want to improve quality of life. And cytopenia is our major cause of morbidity and mortality. The graph to the right just shows us that actually what we have done over the last decade is not necessarily improve survival, but shift the reasons for mortality in this patient population. This also is by Garcia Monero in Seminal Oncology, and what it shows is that 5 years ago or 10 years ago, the major deaths were from infection, but we've gotten much better at supportive care in that area, so now most patients do die of complications related to their cytopenias. So how do we manage those cytopenias? As Gail mentioned, the one we see the most often, and probably in about 90% of patients at least that we need to treat with low-risk MDS, our problem is anemia. So the first thing we could do, which is somewhat easy, is red cell transfusions. And we have gotten much better at dealing with alloimmunization. The risk of viral infection is now very low. However, chronic anemia increases morbidity and decreases quality of life. There actually is some data that there's a correlation with the number of transfusions and survival. Again, hard to know whether it's cause and effect. And there's a risk of iron overload. So in 5q- disease, I think we're all fairly convinced that in symptomatic anemia, the treatment of choice should be lenalidomide. In non-5q- disease, it's not as obvious. It is recommended, and I think of benefit, to think about whether or not the patient is a good candidate for ESAs. There are different formulas, but it seems that those who are likely to respond are those who have a low baseline EPO level, have had few prior red cell transfusions, and there is also some evidence that those who have a low IPSS-R are more likely to respond to erythropoietin. And that would be 40 to 60,000 units of erythropoietin weekly, or 300 micrograms of of Aranesp with or without GCSF. You have to remember that it can take 8 to 12 weeks to respond, and responses can last up to 2 years. It's also been shown, interestingly enough, that the use of ESAs may improve overall survival in low-risk MDS when compared to transfusion support. Whether that's because you no longer have chronic anemia, which is leading to cardiac dysfunction, or things of that sort, it's not clear. This is one of the erythropoietin predictive models that is quite useful, gives scores for the things that I mentioned: serum EPO level, transfusion units, number of red cells that they've had, and the likelihood of response then is anywhere between 7% to 75%. So 75% chance of response in those who have a low serum EPO level and have not required many transfusions. This is just a quick look at whether or not there is a rationale behind iron chelation in this patient population. We all know that iron overload is a problem. We extrapolate from the data on thalassemia that there would be a benefit to chelation. It has never been shown in MDS that either the complications of iron overload are clinically significant or that reversing iron overload leads to a benefit. All we know is that those patients who get iron overloaded do not do as well, but that could just be a marker of their disease. This was a meta-analysis trying to see whether or not there was a survival benefit to iron chelation, which looks like there is. There is a current prospective trial ongoing to try and answer that question, and it'll be interesting to see what they come up with. Now, how about a management of anemia in those patients who fail ESAs? So this is transfusion independence after Vidaza. It happens. 50 to 60% of patients who have low-risk disease do develop transfusion independence, but there is a cost, as I mentioned. There is a cost of toxicity. There are very few patients who die of Vidaza therapy, but it's not zero. And the majority of patients develop significant cytopenias that do impact both on their quality of life as well as increase their risk of infections. So what about lenalidomide in non-5q- disease? The original lenalidomide studies were done in low-risk MDS patients. The original phase 1-2 trials included 36 patients, of which 2/3 of them had erythroid responses. The majority of those patients happened to have 5q minus disease, which is why the next set of studies separated those. The 2 phase 3 studies that were done, there was one study that looked at patients with 5q disease and one study that looked at patients who did not have evidence of an abnormality of 5q. What they saw was that in those patients who had 5q abnormalities, 2/3 became red cell transfusion independent, another 10% had a 50% reduction in their transfusion needs, and that could take up to 12 weeks to see a benefit. It often was associated with cytopenias before they became transfusion independent that could often be severe and require discontinuation or lowering of the dose of the lenalidomide. And the majority of these patients had long-lasting improvement in their red cell transfusion needs. In those who do not have a 5q abnormality, about a quarter still became red cell transfusion independent, and another 17% had a 50% decrease in their need for red cell transfusions. The median time to transfusion independence was 5 to 6 weeks, and the median duration of transfusion independence was about 10 months. In this patient population, there was no relationship between cytopenias and response. However, a quarter of the patients did still become cytopenic before they developed a response to lenalidomide. Now the next question is, I've shown you that both azacitidine and lenalidomide can work in the transfusion dependent patient who has failed ESAs. Does it matter which one you try first? And this one study, which was a retrospective analysis to ask that question, what happens if you give lenalidomide before azacitidine versus azacitidine before lenalidomide? And although I've not shown the responses here, the responses to azacitidine were the same regardless of whether you gave it before or after, but the responses to lenalidomide were significantly higher if you did it first. So there was about a 35% response rate to lenalidomide if given first, but only about a 10% response rate if given after azacitidine. And what this translated into was a survival benefit to those who got the lenalidomide first and the azacitidine after lenalidomide failure. So those who got lenalidomide first had a 104-month survival, while those who got azacitidine first had an 87-month overall survival, suggesting that you should give the lenalidomide a try first and give them the best chance of response to lenalidomide and then only consider azacitidine at that point. What else is going on for clinical trials for anemia? Well, there's a trial that has come out of the French, a European group looking at lenalidomide with and without erythropoietin. What they showed was that even in those patients who were erythropoietin failures, the combination of lenalidomide and erythropoietin in those with non-deletion 5q low-risk MDS led to hematologic improvement in 40% versus 23% of those who did not get erythropoietin, with transfusion independence in 25% versus 13%. The response duration was no different. There's an ongoing cooperative group trial that's asking a very similar question. And then there are some new agents that are being investigated for anemia. Most of them are signal transduction inhibitors. The 2 classes of signal transduction that are being inhibited are MAP kinase, P38 inhibition, and TGF-beta. One that was presented at ASH this year, Luspatercept treatment looking at increases in hemoglobin. I have here Luspatercept is an agent that will inhibit TGF-beta, which is thought to drive ineffective erythropoiesis by excessive SMAD2/3 signaling. This was a study where patients with low-risk MDS were given subcutaneous injections every 3 weeks. It was a kind of a phase 1-2 trial. The base study looked at a dose escalation phase, and then they did an extension study in an additional 24 months of treatment. The baseline characteristics of the patient essentially was that the majority of them had a lower EPO level, and they had all low-risk disease, IPSS low and INT1 disease. What you can see here is that more than 2/3 of patients with low transfusion burdens had an increase in their hemoglobin and had hematologic improvement. And about the same number of those with high transfusion burdens also had hematologic improvement, and about 40% of those became red cell transfusion independent, with an additional 3 patients who had low transfusion burden, not mentioned earlier, who became transfusion independent. As for duration of response, it looks like those who develop transfusion independence, at least for the 8-week period in which they're looking, the majority of them have long duration of transfusion independence. So their conclusion was that those patients who are treated with Luspatercept have a robust hematologic improvement. It was generally safe and well tolerated. Patients who were treated up to a year had sustained independence, and those who were refractory or intolerant to prior ESAs seemed to do better than those who had failed prior ESAs. There's a phase 3 trial currently being planned. Now, what about thrombocytopenia? Not seen as frequently, but probably more complicated and more problematic in those patients in whom we see it, and that's often why people will rush to give hypomethylating agents, because they figure they can't really make things worse than transfusion-dependent thrombocytopenia. Well, thrombopoietic growth factors have been tried as well. The first generation led to worsening thrombocytopenia. Romoplastin, which has been used, did show some improvement in platelets, but there was a concern that it increased the risk of leukemia. That is actually not borne out in the final results. However, Eltrombopag or Promacta has actually been shown in vitro to kill leukemia cells, and so that has actually led to an interest in using Eltrombopag in the MDS patients. So this was a presentation again at ASH this year on low-risk patients with who were given Eltrombopag. It was a multi-center trial focusing on quality of life. Patients were included if they had a platelet count of under 30, who did not have other options they were considering at the time. They were allowed to get growth factors as well. The primary endpoints were the number of patients who obtained a platelet complete response. And as you can see here for platelet responses, this is Eltrombopag versus placebo. So 41 Eltrombopag patients, 17 placebo patients, 12 responses in the Eltrombopag group, none in the placebo group at 8 weeks. At 24 weeks, there's 24 patients who are out to the 24 weeks. There are 5 responders in the Eltrombopag, 3 in the placebo group. Time to response for Eltrombopag median was 14 days, and this was at a dose of 50 milligrams a day. Mean changes in platelet counts at 8 and 24 weeks. As you can see, there was a significant change in the platelet count in the Eltrombopag group, which was not seen in the placebo group. Factors associated with response to platelets, again, was just whether or not they received Eltrombopag, and interestingly enough, their baseline hemoglobin seemed to influence whether or not they had a response to Eltrombopag. Interestingly enough, they saw not only responses in platelets, but also some erythroid and some neutrophil responses were seen in the Eltrombopag group. We have actually similarly seen that in our experience with Eltrombopag. So at 8 weeks, 4 cases had experienced erythroid responses, and 4 had experienced neutrophil responses as well. The side effects were minimal. There were minimal grade 3, 4 side effects, some hyperbilirubinemia, some hypertransaminases, a little bit of pruritus, and as expected, nothing that would be related in the placebo arm. So their conclusion was that in those patients with severe thrombocytopenia, the toxicity was manageable. There were platelet counts did rise and were durable. There was no progression to AML. And there was also some improvement in other cytopenias and was associated with improvements in quality of life as well. And then finally, the other treatment we should be thinking about in these patients who have low-risk MDS is deciding whether or not these patients are candidates for immunosuppressive therapy. It's thought that bone marrow failure linked to T-cell-dominated autoimmune process would lead to some benefits with immunosuppressive therapy with ATG and cyclosporin. Also, rabbit as opposed to horse globulin might be of benefit. What seems to be associated with responsiveness is young age, low IPSS, HLA-DR15 positivity, a short duration of red cell transfusion, and also probably hypocellular bone marrow. ATG and cyclosporin together seems to give you a better response than ATG alone, but it increases the nephrotoxicity. And Campath has demonstrated some responses in patients as well, but it is a little bit more difficult to tolerate and has some other toxicities. This is a randomized trial of ATG cyclosporin versus best supportive care, showing a survival benefit to those who get the ATG and cyclosporin. So overall, in low-risk MDS, I think what we can conclude is that cytopenias result in decreased quality of life and impact on survival. A variety of agents are available, both old and new, and in clinical trial. While patients with low-risk MDS may respond to hypomethylating agents, there is significant morbidity and a little bit of mortality. And the best treatment with transplant, again, has a higher morbidity and mortality. So I think we need a better understanding and characterization of the lower risk MDS patient. Maybe we can then understand which treatments will benefit which patients, and then should be able to outweigh those, weigh those risks and benefits and select the optimal therapy. Thank you.